والكوميونيكيشن سكيلز والكلينيكال سيناريوز والكلينيكال مانجمنت. طبعا الوضع ده اتغير السنه اللي فاتت، ان هو بقت بس سيلف اسسمنت بسبب الكوفيد، ان هم ما عملوش اي انترفيوز، والسنه دي هم قرروا ان يزودوا الانترفيوز عليها. احنا في السيشن دي احنا مش هنتكلم قوي صراحه على الابلكيشن نفسها والبورتفوليو او الابلكيشن خصوصا، يعني لان هي انت هتملى الابلكيشن الاونلاين وفي السيلف اسسمنت، وهتلاقوا الجايدنس بتاع السيلف اسسمنت موجود على اوريل نفسه. نزلوا واقراه، هم هيمارك يو ازاي. يعني هي ستريت فورورد يعني. وممكن لو حد يعني ممكن نبقى يعني خلاص هو فاضل يومين اصلا، فيعني ان على السيلف اسسمنت نفسه ممكن نبقى نعمل سيشن تانية later on للناس اللي got interviewed، لو عرفنا اي معلومات زياده على موضوع البورتفوليو ستيشن. هل هي ماركت زي قبل كده، ولا هم بس هي ابروف الايفيدنس اللي الناس uploaded already في بعد اللونج ليستنج. احنا زينا زيكم مش عارفين تفاصيل قوي في الموضوع. بالنسبه للي مكتوب اونلاين على الانترفيو نفسه، فهو في ان هو غالبا هيبقى 35 minutes الانترفيو، تو انترفيور، 2 consultants، تقريبا 5 minutes عشان تقرا التو سيناريوز، وبعدين هيبقى 10 minutes for clinical scenario و10 minutes for management scenario، وبعدين يمارك يور portfolio. فهو ده فاحنا اللي احنا هنقوله النهارده، او اللي ياسمين ورامي ومحمد كمال هيجوين اس كمان شويه هيقولوه، فهو ده من الحاجات اللي احنا قريناها والخبرات اللي خدناها من اخر انترفيو حصل اللي هو كان من سنتين. ممكن يبقى فيه تغييرات، ممكن يبقى فيه بسبب ان دلوقتي مثلا دول 10 minutes، ممكن ان هم عايزين يزودوا مواضيع تانية او يخلوها more complex بما ان الوقت اطول، او يزودوا حاجة فيها كوفيد. كل حاجة يعني ممكن تحصل، بس اعتقد ان الطريقة اللي بيتجاوب بيها الاسئلة في العادي مش هتتغير عن او السكيم اللي المفروض الماركينج سكيم والحاجات الاوبجكتيف اللي هو بيبقى عايزك تقولها يعني في الاجابه بتاعتك. ما اعتقدش انها هتتغير كتير، ممكن الابروتش يتغير شويه، بس ما اعتقدش ان البوينتس نفسها او الحاجات اللي هو بيماركيو عليها هتتغير. فانا دلوقتي خلاص خلصت المقدمه، هسيب رامي هنبدا بالكلينيكال سيناريوز. وفي سؤال كان من حسن I think على الشات، كان بيقول هل السيشن هتبقى بالعربي ولا ايه؟ كلها بالعربي. هو الانترودكشن كانت معظمها بالعربي، السيشن نفسها غالبا more it will be in English، والديتيلز والكيسز والشرح هيبقى more in English. لو في اي اسئله بكتبوها لنا على الشات وهنحاول نرد عليها، او هنبقى نسيب جزء في الاخر لو في حد عنده اي اسئله.
اوكي طيب معلش قبل ما ابدا ممكن بس كلاريفاي مع حسن. سوري can I clarify with Hassan, are you okay with Arabic or
sorry, no, I don't unfortunately speak Arabic. One of my Egyptian colleagues recommended this to me, and as soon as I logged in, everyone was speaking Arabic, so I'm a bit confused, but I get parts of Arabic, so.
No, that's fair enough. I guess it's a bit short notice for you to learn Arabic, so probably
a bit too short notice. but if as you said, if you could elaborate on the station scenario and all that in English, that would be great. Fair enough, the introduction was in English, in Arabic, so that's fine. But thank you for having me.
No, I think we should just give you a very quick summary in Arabic about what Amira said, and then we'll and then basically just we'll carry on with English. I think Amira was just introducing about the changes that's happened in the interview, and she mentioned about that's the only thing that we know from the new setup of the interview is that it will be a 35 minutes interview with 2 consultants as interviewers. It's 10 minutes. It's 10 minutes for the scenario, and then 10 minutes for the management scenario, and 10 minutes of the portfolio question. Really just verifying evidence. We don't know much more than that, but hopefully in the next few days then after shortlisting essentially there will be a bit more information. Okay? So just before I start, I just want to tell something to the colleagues who introduced themselves. So just to the colleagues who just started in the UK, we've been in your shoes 5 years ago, and I think you've done the right things just to try to approach this pathway, because I mean, I think for us, we've done this quite late after 2 or 3 years of being here. And I think if you just have a go, even if it's not that successful this time, it's a good. So you'll have that pathways being explored, and you know exactly what you want to do. And then when you apply next year, it will be much easier for you at least to make a decision whether you want to pursue that pathway or not. And a word to Ahmed Sulaiman, our colleague, who I guess he's done quite a lot of work before, and he's thinking of the Caesar pathway. I was certainly exactly in your situation 2 years ago, and I applied. I didn't know really what to do, whether to carry on or not, and I took steps towards the Caesar pathway. But then at one point it stopped, and I just reassessed my situation, and I thought whether that would be the right thing to do or not. Till this point, I can't tell you exactly whether this is the right thing to do. It might have been the right thing for me to do, but I don't really know what you think. I remember the first time in the interview, I was very well prepared for the highest degree exams, and basically I just went to the interview and I've done really badly because I didn't prepare for that interview. But what I figured out is actually the preparation in terms of portfolio for this interview is exactly the same as the preparation for the Caesar application. So you won't really waste time by preparing for both and trying both. Well, that's what I would think. Right. So now we are going to start with the clinical scenario station. So previously there was even more than that. It was 5 stations, and it was a bit more complex pathway. But I think at the moment they're just minimizing this to only 2 stations, and a portfolio station is just verifying evidence. So my thoughts are there might be a little bit of they might complicate a little bit of these interviews stations, because I think they give you more time, as Amira said, and also they would like to assess your communication throughout the interview. So they might add something just to assess your communication a bit more in these scenarios, which hasn't happened previously in the previous setup clinical scenario stations and management stations. And yeah, so I think, and as they are shortlisting people, so I think they're now looking into assessing people at higher level, as they're not really interviewing everybody, just interviewing what they think are the likely successful interviewees. So let's start with the clinical scenario station. What is this all about? So I think you'll be more familiar with this sort of clinical scenario stations, because that's what you've been examined all the way through in your MRCS, in your exams from back home. But it's not as simple as what we've been through before, because it's not only that asking you a question about a case and then you find out about a diagnosis and a set of investigations. It's a bit more than that. It's actually the management of the situation completely, and acting as a leader and managing your team and dealing with the clinical and the non-clinical issues. I know the non-clinical issues sometimes will be more assessed with the management scenarios. However, in here as well, they will be marking you on that. So you'll be marked on the recognition of issues, and basically that's to clarify and be able to identify, so to clearly identify the relevant issues there, and that means the clinical issues and the non-clinical issues. 2, you'll be marked against the judgment. So how can you understand what you've been given in terms of information? How can you effectively discuss this, prioritize the issues, and deal with them? Next is planning and use of resources. So it's you, your team, and the resources of the hospital. You need to be able to manage this effectively in the patient's best interest with using the prioritization. And communication strategy, which I think they might put some more weight on this, given that will be assessed throughout the interview. So they might actually increase the weight on this a little bit this time, which assess the communication throughout the case, either with the interviewers themselves or with other team members throughout the interview, or throughout you going through the case. Obviously, you will mark maximum if you manage to mark against each of one of these 4 parameters without any prompting. If you answer with prompting, you will mark a bit less. But if you with prompting, you can't get to the point, then you'll mark obviously less. And then the old setup was 2 interviewers. Each one of them will mark you from 1 to 4, and then they will add both marks, and then you'll be assessed on as appointable, not appointable. You fail the station altogether. Next, please. Right. So it's very difficult to make these sessions a bit of interactive, given that we're doing the virtual scenario. So Mim was asking what means of prompting. Prompting means that you don't know that you didn't give the answer, so they will try to push you to give the answer, can give you a clue, can just try to guide you through it till you give the correct answer, which what people have been doing to us in all the oral exams in the past. But yeah, it's named prompting. But if you say straight away the answer without being prompted, that is how it is. Actually, you're meant to give the answer even without being asked about it, if you know what I mean. And we'll see how would we do that now.
رامي من غير ما اقطعك، بس ممكن حتى تشرحها بالعربي ان هي يعني ايه بالعربي بسرعه.
prompting بالعربي يعني يحاول يزقك انك تجاوب الاجابه. يعني انا ما اعرفش فعلا ازاي ممكن اقول الكلمه بالعربي، بس هو ان انت ان هو مثلا تبقى انت مش يعني انت مثلا ما قلتش ان البيشنت عنده الحاجه الفلانيه، فيقول لك طب وانت في حاجه ثانيه عايز تبص عليها، طب انت عايز تعمل له حاجه ثاني، يعني بالشكل ده لغايه ما انت تجاوب. لو ما جاوبتش يبقى انت هتسكور مينيمم. اوكي طيب. So we've got a case here. Usually what happens in the exam that you will have 5 minutes to read 2 scenarios. One of them is a management scenario, and the other one is a clinical scenario. This one is a clinical scenario, so ideally it will take 2.5 minutes to read through it and to gather your thoughts and how to gonna deliver your answer about it. And the question is always, how will you be managing this case? Okay, so you got this case in front of you now. You will have, this time you will have 1 minute to think about it, and which will be starting now. And then there'll be a role play between me and Yasmin. She will be the interviewer, I'll be the interviewee. And think of what I've done in the interview, what would you do differently? And then we'll revisit this case again at the end of the presentation and see how can we modify our answering strategy. Take your time. I think I'll start the minute now, okay? Okay. Right. So, Amira, can you, yeah.
Okay.
You make part now, yeah.
طيب Rami, what do you think is the diagnosis of this case?
I think this patient is likely to have a large bowel obstruction because it's got abdominal distension, vomiting, and his X-ray showed peripheral bowel loops, which is more significant, also suggestive of a large bowel obstruction. His blood also showed a degree of a dehydration and sepsis, I would think. And he needs, I think, resuscitation and drip and suck. That's to correct his dehydration and electrolyte imbalance. I'll probably do an abdominal X-ray for further assessment, and he's likely to have a CT scan as well, just to confirm the diagnosis, which we should do at some point. And depends on that.
You've done the X-ray, and that's what it shows.
All right. Yeah, that agrees with what I thought actually from the description. That looks like large bowel loops, given the house ratios, and it looks like the obstruction towards the
What else do you want to do?
As I said, I think I would do a CT scan for the patient just to give me more of a clue, and depends on the CT scan results. I will decide whether this patient needs to go to have an operation, whether it's a heart muscle operation and colostomy or something, which will need to be booked and consented for.
So you've done a CT scan, and that's the imaging. That's the result. What do you think there is?
I think the appearance can be suggestive of distended bowel loops. It looks like large bowel loops here on the left side, which agrees with my diagnosis as a large bowel obstruction. And I think this patient, yes, he will need to have some resuscitation, and then he will be considered for an operation.
Okay, so when would you do the operation? Do you want him to take him to theatre now, or do you want to wait until the morning?
I think from the case it says that it's past midnight, so probably it'll be a few hours till we resuscitate this patient, and I'll probably get in first thing in the morning, and I will certainly mention him first on my handover in the morning.
Okay. So it's 5 a.m. now, and the patient is getting very sick. The nurse is calling you and says the patient's complaining about a lot of abdominal pain and it's getting a lot worse. What would you do then?
I will go and review the patient, and given the picture is changed, I will do another CT scan just to see what's happened.
Okay. So the CT shows free air. What now?
All right. Well, this patient has got a bowel perforation, and he needs to go to theatre.
Okay.
So
are you going to take him to theatre straight away?
I think so. I think we'll just take him to theatre.
Do you want to call someone before you take him to theatre, or are you going to just take him yourself?
Oh yeah. Sorry. I will call my consultant, obviously, and I'll tell him about the situation, and we need to take the patient to theatre.
And I'm your consultant now. What would you tell me on the phone?
Yeah, is it a phone conversation now, you mean?
Yes, so you're calling your consultant and I'm the one on the other line.
Hello, okay, hello, I'm the registrar on call. We haven't spoken throughout the night, but I actually had this very sick patient with a CT scan that suggested that he's got bowel perforation, I think secondary to bowel obstruction, and at the moment he's quite unwell, and I booked him to theatre. What do you want me to do?
Okay, so you've already booked him for theatre?
Yes, I did.
Okay, well, if you say they've got an obstruction and they need to go, do you need me to come in? Do you want me to come in?
Well, I'm not sure what you think. I mean, the patient is 5 o'clock in the morning at the moment, and but he's pretty sick. So, I mean, I think my thoughts is it might be better if we take him to theatre now.
Fine, okay. And you need me to come in for you to go to theatre, yes?
Yes, I haven't done it many times myself, so I would appreciate if you come, please.
Okay, no problem. I will be coming.
Thank you.
Thanks. Bye. See you in a bit.
Right. Okay. So, thank you, Yasmin. I'm not sure what are your thoughts. If you just get next slide, I think it might be a free air on the next slide actually. So just gather your thoughts about that. It is not. Just surprisingly, guys, it is not that different from what happens in the real interview. You're not yourself. You're delivering answers in a funny way, and it's quite a lot of stress. And you can have a very manipulative interviewer. And it's as I said, you will be surprised what you say in the interview. Okay, and actually, not many things that I've said is wrong, but the delivery was not the best. Okay. And we'll revisit that case again with a different scenario of approaching the answer after we just go through the answering strategy in a minute. Okay, can we just move on? Perfect. So this is basically the answering scheme. We haven't invented this. This basically is just our experience from the preparation material that we've been looking through when we're preparing for our interview. And I mean, different sources will give you different things, but that worked for us, and I think it's good, and it's applicable to most of the cases, and it actually takes the books as again, it's the marking scheme as well. So when you deliver the answer, what you need to do, what your objective is actually to deliver a complete, quite well delivered answer, just including everything. And I know lots of people who hasn't been interrupted for once throughout the interview, and when they finished, they take all the books and they got answered nothing. They got asked nothing afterwards. So this is your objective, is basically just to deliver a complete answer from the start that you won't get interrupted afterwards. Okay, so your answer should address the clinical issues, the organizational issues, and I'll tell you in a minute what does that mean, and to address the priority, which will be all of the patient safety, but what sort of priority you're talking about, that's important. And then what's your initial action as you know about this patient, and as you go through the patient and finish off with all your assessments and the initial action, then finally comes a definitive management. And here we're talking about definitive imaging and plan for escalation and timing for escalation and plan for intervention if need be. I think we're missing something at the bottom. Is that right, Yasmin? Can you maximize the, yeah, thank you. And how to deal with other issues that you've identified first. So it's clinical issues, organizational issues, what's your priority here, what initial actions in terms of management of this patient, and what is the definitive management, including the definitive imaging or investigation and the plan for an intervention. Good. Move on, please. Thank you. So let's talk about the clinical issues. You need to answer the question. This case is about a clinical condition, and you need to deliver a first sentence to say what actually is the problem here. What do you think is the problem, and what do you think the likelihood of the sequence of event afterwards? But also in a brief way. You don't really need to give too much reasoning here. You just give it in a brief way. But you also can mention here, if you don't have the answer completely, and you might be in some scenarios just giving you one symptom, which is still vague and needs more investigation, just to say what you got. So you don't need to make something up. You don't need to push yourself to the border to get a diagnosis which is not clear from the start. And then if you don't know the answer, it's better if you just give them a room to prompt you a little bit so you can get to the answer, rather than dig yourself a hole and go through a final diagnosis that you're not sure about, and then the whole base completely, the whole station is completely gone for you. So that's the main thing. What is the likely diagnosis? What are other important differentials that you need to exclude or rule out, or you might be considering in your differentials? So you might say, okay, I think this is a case of intestinal obstruction, but it doesn't give you any clue at all whether a large bowel obstruction, small bowel obstructions, you don't really know. So you say, the patient's presented with this is a likely intestinal obstruction with dehydration, and the top of my differentials will be cancer or adhesion bowel obstruction or hernia, okay? And then you mention at the end, what is the likely definitive course of action? So as an example for this case, it is a likely large bowel obstruction with dehydration, and this patient needs a resuscitation, urgent imaging, and likely intervention, which is theater for laparotomy as an example, okay? And then you need to address any other clinical issues, which this is the tricky bit actually. This is the bit that we're not used to, is to try to identify all the other clinical issues and mention them clearly, because the answer sheet will have all these clinical issues there, and they will be ticking any state that you identify or not identified. And if you don't identify any of those, then you'll be prompted to it. This is not the exact case, but this is the case I had twice in my interview in different stations. Not exactly the same one, because we're not allowed to show you to tell you the same what we've got in the exam, but it's exact same idea. Okay, so the other clinical issues can be a medication, a problem with the patient on anticoagulation, immunosuppression. The patient has got sepsis, has got dehydration, acute kidney injury. Patient has got associated medical conditions, which will basically have an impact on the suitability for going to theatre. And I think always here, amongst the clinical issue, we should mention about COVID these days. Either the patient's got a symptom of COVID or the patient's got undetermined COVID. So you need to mention it in some way. And I think people will be prompt to mention that if they didn't do it. Okay, next. So now we're done with the clinical issues. Now, organizational issues. I'm not going to go through this in detail because actually the management scenario or the management cases which Yasmin and Mohammed will be talking about will be all around organizational issues, and that will be the main topic of the scenario rather than a clinical issue. However, as you will see, there will be organizational issues and clinical issues in both scenarios, and you need to be able to identify both, and you're not allowed just to drop them. So here's an example. You have a team, you need to mention what you're going to do with the team, and there will be something there might be something in the case to tell you that actually you've got a problem with the resources and you need to prioritize an example. Team management, you might have an underperforming F1, like you've seen the patient and didn't tell you for hours, and then now somebody else, the nurse is calling you as the patient is deteriorating. So you need to do, so to mention something about that. You've actually identified this problem and you're going to deal with it later, and you remember to deal with it later actually. Training issues usually doesn't come here quite much, and it usually comes more in this one of the common themes that comes in the management scenarios. So next. Patient communication, this will come in your clinical scenario. It will definitely come. You need to mention about it, and you need to know it in a bit more detail, really. Okay, there won't be a scenario where you won't be in facing consenting issue. You won't be facing an issue with a child or an adult without capacity. DNA CPR, you need to contact family with pretty much every single case. Other less common things like Jehovah's Witness, language barriers, how to deal with all these things, we'll leave it to the management team to talk about. COVID-related issues, I think I would definitely mention COVID in every single case these days, because let's go one step back. Thank you. So because COVID status now is like it's been added to it's nearly added to the WHO checklist, isn't it? COVID status with every patient that affects the timing for surgery. It will entail the staff and colleagues' safety. When you talk about PPE and not PPE, what are you going to advise the team? What are you going to do with yourself? Consenting, every single patient attending hospital these days, I think, should be consented for additional risk because of the COVID. If they catch COVID, which will increase which worsen their morbidity and mortality from the procedure. And in my own hospital here in Dundee, we have a separate consent form for COVID with every single patient that's going through an operation, regardless what he's being consented for his surgery. Okay, next. Now, priority. For those who had some experience from previous years, I mean, when we're talking about priority, people just used to say that my priority is a patient safety. Yes, and I think you need to say it that way. But I think you need to explore the meaning of it in a bit more detail. So at that point, they were expecting you to say, because now you're starting to plan for your management, what are you going to do for this patient after you address the issues quite correctly? You need to say that the cornerstone of my management of this patient will be the patient safety. So how will that will be the one thing that will guide whatever I will do from now on, okay? And you need to mention what actually are the elements of the patient care that you will address as a priority. So it might not be the priority to take the patient straight to theater, but certainly the priority for this patient to be a resuscitation, to be investigations, immediate escalation, and it might be theater if you're facing like a leaking AAA case, okay? So you would mention what actually are the elements of priority that you will prioritize with this patient. And a bit more, you might say actually, my priority is patient safety, and this patient is my priority, because they might give you few other cases that's happening at the same time. They might tell you, actually, you are dealing with a patient with PR bleeding but stable, and another young patient with query appendicitis but stable, and you got this patient. So you need to mention here that actually, I got more than one patient, but this patient is my priority, and my priority with this patient is resuscitation, investigation, and doing this and that, okay? The prioritization would be quite key in the scenarios where you have very limited resources. As an example, all theaters are occupied, or the single emergency theater is occupied, and you got a leak in AAA. So you need to say clearly here, my priority is this patient going to theater. We need to open another theater, full stop. Okay. might be fighting over ICU beds and you need to prioritize. And here comes a bit, your prioritization, however, dealing with other teams as well and getting support from your consultant and from other teams. Or sometimes the prioritization is important, as I said, when you have more than one unwell patient and you need to mention clearly what do you think is going on, what are you going to do to prioritize. Next. Right, so here's initial management. So just imagine yourself now handling the phone and you're getting this referral from the F1 or any fellow or whoever about unwell patients. Your management will start from there before putting the handle of the phone on. So before hanging up, you need to start your management. Again, different people, different approaches. That is my approach. I used it in the interview and it was quite good. And I think people were happy with it. I think I scored maximum in this particular station. And if you do it repeatedly, you have a system, then it will make it easier for you. And honestly, if you apply it in your practice, it's nice as well. So what I usually say is, whenever the referral is done, that is my opportunity to gather as much information as possible about the patient. That will give me a better idea about what I need to do, because I know for sure that after putting the handle of the phone, I need to make a decision about what I'm going to do next. I might have got another unwell patient, and if I just get the minimal information that somebody's handed me, I might not be able to make a decision about really which patient is my priority. So I need to get as much information as possible to make that decision, and two, to tell people what to do. So next, give these people on the other side of the phone some instructions, some things to start. And most importantly, as you mentioned about patient safety as your priority, then make sure that the patient is in a safe place. If they're talking to you about an unwell patient with a peritonitic abdomen, sat there in minor or in a chair in the waiting area in A&E, first thing to say, move this patient to recess now. That is a safe place. Two, get starting the initial management technique. Get decent access, give the patient IV fluids, send bloods. If the patient is septic, start antibiotics promptly now, get culture sent by the time I will come, okay? If you get referred a leak in AAA patient, proven in a CT scan, full stop. What you need to do, the first thing you will do after you put the hand down, is speak to theatre and say, we'll put anything on hold because we've got a leak in AAA that we are going to assess still, but till that happens, don't get that 20-year-old query appendicitis for a diagnostic laparoscopy yet, okay? And the other thing that we do over the phone is to update the team of your situation. As you usually in these cases will make your priority as to go for this particular patient, then you will say, okay, this patient is my priority, I'm coming now. All right. So at the moment, you know yourself what's going on. You spoke to the guys on the other side about the situation, updated them on what they need to do, where to put the patient, and what are your initial thoughts. Three, organizing your own team. You're not alone, and you will be assessed for your management and working as a leader in the team. And although your consultant is the manager of the team, you are the leader of this situation. So you need to manage it that way. Okay. So first of all, you arrange your own priorities and the own workload. Oh, this is a busy on call. We got 6 patients to be seen and I got 2 people. So I'll ask these people to come and start seeing the patient by the time I'll go down and assist the patient who's in resus. That means it's probably okay and I don't need a second hand. However, another patient in the ward falling off, what you need to do is you need to get one of the juniors to come and help you. So we'll be doing bloods, helping with resuscitation, getting fluids done by the time you assist the patient, requesting CT scans and things. So it is a dynamic process. It's not only one answer that fits all. So you need to think through it, okay? Delegate jobs, as we said, it depends on what we do. If I'm missing any important question, Yasmin will stop me, hopefully. And escalate to a consultant. I wouldn't usually escalate at that point unless there's a very clear story that this patient is unwell and is needing immediate theater or needing immediate attention from a consultant. So if I got a referral with a leak in AAA, first thing I do after I do this is I call the consultant and say, we've got a leak in AAA proven in a CT scan. I'm gonna get theaters on hold. You make your way. I haven't seen the patient yet. That is appropriate. However, if you got a referral of a bowel obstruction for a stable patient, I don't think it's that appropriate to mention that you called consultant now, because next thing they will say to you, the interviewer, is, okay, well, I'm the consultant on the phone. Tell me. And then you'll tell them the very pathetic story that you had from the A&E F1, all respect to everybody, but you haven't seen the patient. So essentially, you won't be able to help him making a decision. And second thing, he will say, okay, well, I will come because I don't think you're giving me the right answers. So be careful when to escalate. And if you, in my opinion, if you question yourself whether to escalate or not, I think you should escalate, okay? Because in our practice, even from back home, from Egypt, as the most of the attendants are from Egypt, we used to act like a one-man show and just try to be proactive and do things and then tell people late. We don't like that here. Okay, next. Thank you. Right, so you haven't really even seen the patient yet. So then all these things, you're just preparing the scene down there and you're updating your team, what you're doing, you're getting help, you're updating your consultant if it's ready, and you are letting people who are key persons like a theatre coordinator or something to know even before you attend the patient. On attending the patient, first thing I actually used to say is I will get a final update about the situation again, just in case the patient is deteriorated again, and then almost always CRESP assessment. Don't say I'll do an initial assessment ABCD. No, you say CRESP, following the CRESP protocol. These are the buzzwords. You've got the CRESP written in front of him and you want him to put a tick in front of that. So you need to mention CRESP protocol. If it's a trauma case, you would mention ATLS protocol and you would break it down to its own elements. So as you know, guys, I'm not going to go through this in a bit more detail. So A to E assessment, IV access fluids, oxygen catheter, blah, blah, blah. If the patient is septic, you give sepsis 6. And sepsis 6 needs to be said as sepsis 6. And what happened in my interview, he asked me to break it down and I broke it down and I got full mark on that. You know what I mean? So you need to mention it that way, okay? Because if you said, oh, I actually mentioned everything. I mentioned about culture, I mentioned about urine catheter, but I didn't mention the word sepsis 6. No, this is not what you want. You want to make sure that you know what you're talking about and it just hasn't happened haphazardly, okay? Next thing, history taking. Again, people tend to go through the history all alone. You don't need to do that. You say, I will take a full history, and the main elements will be asking about this to justify this, this to know this to help me with this, okay? Because you don't have much time. Don't bore them, because the minute that they will get bored, then they'll just lose interest, okay? Examination, again, I'll do full general and abdominal examination. And the general examination mainly concentrating on like signs of dehydration, malignancy or whatever. And an abdominal examination looking for this and that, okay? Charts and notes, it will be important for confused patients to say, actually, I look at the notes, I look at the electronic notes, I'll try to gather as much information as possible from that. Then investigations. And here you mentioned about the basic investigations, because investigations will come again when we're talking now about definitive management as a, what is a definitive investigation, okay? So here you will mention about the missing bloods. So as an example in this scenario, they didn't mention about amylase. And you'll be asking what actually is the missing blood test. So if you don't have it in mind, you'll get confused and then you just go flip the paper, try to find out actually what's missing, and it's unnecessary. So you probably just remember about the important one that usually they miss. Amylase, lactate, ABG, CK, troponin, D-dimers, clotting, these things that usually are getting missed, or they're not actually at the backbone of the sort of ordinary bloods. ECG, X-ray, pretty much everyone will have an ECG and X-rays. Okay, X-rays you need to tailor it a little bit, depends on the case. And then talking about the management, don't forget about medication. It's such a simple thing. You say, well, I'll give the patient symptomatic management, because the patient won't be really suffering with pain and you're just carrying on with things without really addressing that simple issue. So give the patient antiemetic, give the patient painkillers. But other important ones as well is that tranexamic acid for trauma is quite important. Tetanus immunization assessment is quite important in patients with penetrating injuries. Antibiotics in septic patients, these little things will make difference. Other things in the management that apart from the definitive management, like blood products, somebody's needing transfusion, somebody's on anticoagulation, and you're thinking about BCC or platelets or fresh frozen plasma, whether to give them vitamin K, all these things. Okay, such a simple thing that they will be looking at it. And when they ask you the question, you'll be automatically thinking of the most complex thing. They're asking me about this fancy blood test. No, they're asking about amylase actually. Okay, next. So definitive management, and here we're talking about just the pinnacle of the case. Just what is a definitive investigation that will give you the answer or confirm your diagnosis, and from that, what are you going to do, and taking you through the process of the action of what you are going to do. As this guy said in the first example, oh, I'm going to take the patient to theatre. Is that good enough? I don't think so. You need to break it down to the element that you guys all do it in your hospital. However, when it comes to the test, to the exam, to the interview, you're just giving them like the final answer without really breaking it down. This is not what they want. They want to see your attitude. They want to see what you're actually gonna do as an ST3 first day in your hospital as a trainee. Okay, so definitive imaging investigations almost certainly will be CT. Okay, sometimes endoscopy is the answer. So it's not certainly imaging all the time, but it's most of the cases. And at that point, be prepared that they will divert the case. They will be giving you some imaging for you to be able to interpret, like what happened in this case and what's happened with all of us in the interviews. Or it won't be the most complex because you don't really have PhD in radiology. You're just an ST3, and their expectation about somebody who's finished CT2. So how much interpretation of a scan will you have? Not really much. Okay. So don't think complex, just think very, very basic, okay? And then they can actually change the scenario. And they tell you, like, what happened there is actually this patient is deteriorating, what you're gonna do. And usually that happens either when you do badly, that means they're trying to prompt you by giving you a more clear scenario about what's going on, or sometimes that can happen when you're doing very well. So taking this to a next level, because you're just taking all the boxes, they're just taking it to a next level. That's what we've been experiencing in all our oral exams anyway, wherever we had our medical education. Okay, so after you have the definitive investigation, at this point you'll be expected to have the answer about what's going on and what you need to do. Okay, they will give you more information. If you had all the information ready already, then you will have the answer here. And then, if you didn't mention before about escalation, you should escalate here. Okay, sometimes escalation can come before or after the CT scanning, and sometimes there's nothing wrong about saying, well, I need to get a CT, an urgent CT scan, which I will order, and I will speak to my consultant and update him about the patient, give him heads up, and while we're getting the scan at the same time. You do this in a query AAA leakage scenario with a patient who is not known to have a AAA in the past or hasn't been scanned before, or somebody who's quite unwell, but you don't have a definitive answer yet. Okay. And when you give that is very, very important. When you give the answer, when you call the consultant, you need to give him a very, very, very clear answer about what you want them to do. So you don't give them a wishy-washy story of, well, I don't know, might be, what do you think? No, you tell them a clear story. You might not have the answer yourself, but you tell them exactly what you want from them. Okay, and you need to do the housekeeping first. You need to tell them to make sure that who are they. You need to tell them who you are. Make sure that you are talking about the right person, about the confidential information of the patient, and then you give them an introductory statement that tells them exactly what's going on. So if you're calling somebody at 4 o'clock in the morning, they're half asleep. You need to tell them something that will make their eyebrows to go up. And you be very, very alert to what you're telling them. So in this case, I'll say, well, I got a patient with a leak in AAA who needs to go to theatre right now, and I want you to come. That's it. And then when you say that, then you'll break it in details. But probably for just a clinical scenario, they will just stop you at that and they say, okay, I'm coming. Okay. Then talk about the details of the intervention. What are you going to do? So here, probably there will be more than one, sometimes it will be more than one correct answer. Don't just stick with the simple answers. Don't go to the very complex answers, okay? You have it in your pocket just in case they ask about it, because they want you to know what are you going to do in that situation, rather than what are you gonna, if you're gonna answer a theoretical question, okay? the points to mention here, which is quite important to build up to the intervention, is one, risk assessment. If a patient has got too much comorbidities, you say, I'll do a risk assessment for the patient. This patient is for intervention, which is this. Basically, with this approach, this patient is got a perforated appendix and he needs to have that done laparoscopically, okay? Risk assessment, if a patient is got lots of comorbidities, then you mentioned that you will be keen to do a risk assessment. You need to consent the patient, but it's not just I'll consent the patient. So if the patient is adult, you will consent the patient. If the patient is a child, that's a different process. If the patient is confused, that's a completely different process as well. Communication with the family is a key always. And it depends on, as I said, it's just the patient. So if the patient is confused, then the family conversation will be very important. The same for the kids, okay? Contact entity, the anesthetist, the theater coordinator, IR, if you need IR. Obviously, you spoke to the consultant before taking all of this forward anyway. Nowadays, COVID status is quite important as for planning for the timing for surgery, for which theater you're going to use, and if there's another COVID patient in theater, what you're going to do, and all the rest of it, okay? Justifying a quick COVID test as well, which some hospitals are having these days, which you can have the results in less than an hour, is quite important as well, okay? Whether you need to transfer the patient to tertiary, secondary tertiary facility, whether that be HDU or ICU, pre-operative or post-operative, is very tricky, but easy answer, we'll get critical care involved and we make a joint decision, okay? You don't know all the answers. What you need to show is that you're safe and you know how to use your resources and how to deal with other teams and how to have clear communication about your case, okay? So, and then you address everything else that you haven't addressed earlier. So if you've got an underperforming colleague, I think, given that you finished all of it, then that's when you address things and say, okay, and after the patient is safe and has his operation, I think I should address these organizational issues, mainly this colleague who was suffering or was struggling with managing the on-call, sit down with them, talk through the on-call in a constructive manner. I will see whether they've been through difficulties and all the rest of it. And again, I'm not going to go through this in detail. I'll just leave this to Yasmin and Mohammed. I think I'm a bit beyond my time, but next will be same case again. All right, so we'll give you a minute to think about it now after what we've said, and we'll do another scenario of approaching this, and we'll see how we can say exact same things differently to score maximum in your interview. Okay, now there's a minute starting. Just think about it. Okay. Yasmin hasn't been nasty to me, so that's a bonus anyway. Right. Okay. Yes. Shall we start?
Okay, so hello again.
Hi.
All right, same case. Tell me, what do you think? What's the diagnosis there?
I think this is a 70-year-old very unwell patient with clinical picture suggestive of bowel obstruction, likely secondary to large bowel obstruction, which will need to, I'm concerned about closed loop obstruction and bowel ischemia here. And this patient certainly will need to have urgent resuscitation, urgent CT scan, and most likely a surgical intervention in the form of laparotomy. Other clinical issues again here, confusion, probably secondary to dehydration and sepsis, which I can see from the bloods as well, and this patient might need to be escalated his care to high dependency unit. Also, medical issues here are clinical issues here are medical background of the patient, which will make him high risk for any intervention, and that will make me think of a risk assessment for this patient before committing any procedure. Also, from the history, I see that this patient is might be on antiplatelets or anticoagulation, which is not mentioned here, and I would like to know, because that will be important as I'm planning for surgery, and whether I will need to have any hematology review and support for that as well. And this patient has got some shortness of breath, which can be explained by the distended abdomen. However, given that we are in the COVID epidemic, this is in my mind that might be related to this. And also, he's been out and about as well all day, so he might have caught COVID. But also, cardiac problem can cause the same. Then that means I will definitely need to address the COVID status for the patient, get a COVID test, and get some cardiac investigation, ECG and troponin, and get a chest X-ray. Organizational issues here. The major thing actually is the communication. This patient is confused, which will make it very difficult to get a meaningful history, and we need to depend a bit more on the collateral history and electronic notes. Consenting will be a challenge as well if the patient hasn't improved with resuscitation, and that means we need to involve the family, next of kin, and power of attorney if there is one. COVID status. This patient is indeterminate COVID status at the moment. Even more than that, he's got some symptoms. So for the safety of my colleagues, I would suggest that we need to have droplet precautions. And if this patient is going to theatre, we need to be in PPE as he's indeterminate with symptoms. And also I will involve this in my consenting as well, that we are in the COVID status, so COVID-related symptoms will add the risk from whatever we're going to do for this patient. I have other patients. It's a busy on call, so I need to organize my team to be able to cope, and I will arrange my priorities, but it looks like this patient is the top priority here. There are limited resources, including CT and theatre, and I know as this patient is indeterminate COVID, and he's got shortness of breath, I will probably be careful that a CT scan will delay other patients, because they need to clean the CT afterwards and get it ready for others. And also theatres as well, we need to see what is happening in the COVID theatre allocated for this. Escalation, I will escalate to my consultant after reviewing this patient and getting enough information to guide the decision making. My priority here clearly is the patient safety, and it looks like this patient is my priority, and the priority here will be for resuscitating him, getting the urgent CT scan, and probably considering him for theatre afterwards. Other patients are need to be looked after, and that will be by coordinating with my colleagues and my team. And also A&E waiting time should be respected. My initial management for this patient will start as early as having the referral by gathering as much information as possible about the patient, and I'll make sure that the patient is in a safe place, and here I'll ask them to put the patient in resuscitation, given the patient's quite unwell, and make sure that the patient's got access, IV fluids and bloods are sent, including amylase, troponin and COVID status sent, and I would advise them to wear appropriate PPEs given the patient's got symptoms, if they haven't done that already.
Okay, so you managed to get a CT scan done for your patient despite not having a COVID status, and that's the result.
Okay.
How would you proceed?
Right. So what I can see here is a CT abdomen and pelvis. That's axial section of a CT abdomen and pelvis with contrast, and it's showing distended bowel loop on the left side, which looked to me like distended cecum, grossly distended cecum with TI junction. Quite concerning of a closed loop obstruction, which agrees with my with my clinical suspicion. I can't see in this particular image any suggestion of, sorry, on the right side, apologies.
Yeah.
I can't see in this particular image any suggestion of the obstructing agent, which to me, I think it might be a cancer given the patient's age and he's got anemia as well.
Okay. So what would you do? Take him to theatre, or what would be your plan?
Yeah, so I need to assess this patient fully following the CPRES protocol, which I would have mentioned in detail. But I need to escalate this to my consultant. I'll call my consultant about this patient who needs to go urgently for theatre to have a laparotomy.
Okay. So your patient is getting worse, complaining about peritonitis, a lot of pain, and you've repeated the CT scan. Oh no, you haven't.
To be honest with you, in this case, I won't repeat the CT scan. I'll just get the patient straight to theatre. This patient's got closed loop obstruction, and the CT scan is suggesting what actually might look like some air is starting to build in the cecum as well, that this patient's got threatened bowel with ischemia secondary to the obstruction. And what I will do is I will get the patient I will speak to my consultant, I will do a risk assessment for the patient, and I will concern the patient if his confusion is a bit better, but if not, I will involve the family and the next of kin, and I will act on the patient's best interest that he will need to have a laparotomy urgently, which I won't wait till the morning. I'll just do an urgent resuscitation hand in hand with getting him to theatre. I will involve the MDT, the anaesthetist, the theatre coordinator. If there's no available theatre at a time, then we need to open another theatre. Obviously, this patient's got some COVID symptoms and shortness of breath, which can be from COVID, and he's indeterminate. So I would deal with him as a potential COVID, and this patient needs to be considered in the COVID theatre with free PPE, which will be discussed with the team, obviously, and my consultant. Yeah, that's it really. Yeah, you need to have a laparotomy, and Hartmann's depends on the status of the cecum. If the cecum is viable, then it will be Hartmann's, and if the cecum is not viable, then the patient needs to have subtotal colectomy and an ileostomy, which is another element that we need to mention to the family as well about the stoma formation and the implications of that. I'm well aware of the other option of colonic stent, which I don't think is appropriate in this scenario, given how unwell is the patient and the appearance of the cecum and the timing for the intervention.
Okay, thank you very much.
Thank you. Right. Okay, guys, what do you think? Let's get two feedback about what is the difference between the two.
Does anyone want to share?
Hello?
Yeah, go for it.
Yeah. So I think the second one is more systematic, and you are following the headline you mentioned before. So it will make you easily not to forget anything. But I think it's too much to remember all of this in the exam with a lot of stress.
Well, the key is practice. That's the main thing. If you practice it with a lot of cases before the interview, because as you said, it's an exam. It's like an exam. It's gonna come naturally.
I also, there is another comment I need to tell. In the second session, you are give a lot of, I think, unnecessary like comment. Maybe it will consume a lot of time of the session. It's 10 minutes. So if we are giving extra information, is it needed, mandatory or no?
What exactly do you mean?
Like type of stoma, etc. Operation. What stoma we are going to do for the patient or anything? We can say like enough laparotomy.
Yeah. Well, I mean, you may be okay just saying that the patient will go for laparotomy, but if you mention to them, and I'm sure most of you knows that you understand because it all comes from why this patient is urgent, why you would do this for this patient and you wouldn't do for another one with chronic obstruction. That's because the patient's got closed loop obstruction. And what actually make this more of an emergency, that's an emergency, that's more of an emergency because it threatens the cecum. And that will reflect in what you do in theater. So when you mention to them, if you know it and you are happy, then obviously you don't dig holes for yourself, you know. So if you know for sure that you are doing, you just know that the patient will need a laparotomy and that's it. You just say it like that, okay? Or laparotomy and colonic resection, that's it. But if you want to show up a bit more with what you're understanding about the rationale of the surgery, that's absolutely fine. There's not a problem about that at all. The thing that I might think is an extra bit of information that's not needed, and you might dig a hole with yourself. They're actually talking about the stent, but I actually forgot to ask Yasmin to ask me this question because I have this case and I've been asking about colonic stent in my test.
You have to, if you want the full mark, you have to. They will mark you whether you recognize the cecal dilatation or not. If you can say you need a laparotomy and not go into any more detail, but you're not going to get the full mark. And it's, as you said, you're nervous in the interview situation, and you got to forget things anyway. So if you aim for perfection and the full mark, you're going to get a good mark at the end.
Yeah, and why you don't say if you know it? You know what I mean? So
can I make a comment?
Yeah, go for it.
You want to introduce yourself first, because people have done.
Okay, hi. Hi. First off, thanks, Rami and Yasmin. That was very well done, very well structured. Good evening, everyone. My name is Mohammed Ali. I'm an ST7 in Luton and a member of the ESSGB, founding member of the ESSGB. Ahmed, when you go for the interview, what time is the interview now? I think it's about 3 months away, isn't it? So ideally, you should be practicing every weekend from now until the interview. And so that gives you 12 weekends. So by the 10th weekend, this should be flying off the tip of your tongue with no problems whatsoever. And inshallah, that would be the goal that you will achieve by practicing. And you need to practice every weekend at least a couple of hours with find a friend or something and practice together. With regards to the laparotomy question, if you say, I'll send them for a laparotomy and you'll stop, the next question is going to be, what's the laparotomy? What are you going to do in the laparotomy? That's a very, that's what means. And even if you ask any surgeon in the coffee room, I took a patient to a laparotomy, the next question is, what did you do in the laparotomy? What did you find and what did you do? So it's a very fair question for them to ask, and you come across much better. You are much more impressive candidate if you know what you're going to do, if you know what you're expecting and what you're going to do. And you know, that's what they're not looking for, someone who knows how to do this, but they are looking for someone who has foresight and can expect what they'll find and anticipate these problems and how to mitigate them, how to deal with them.
And people who have scored most in these questions are people who didn't have to ask them a lot of questions. If you just talk for 7 out of the 10 minutes and you say everything that they need to hear, they're not going to ask you any more questions, and you're going to get the full mark.
Yeah, so that's happened to many people. Many people just go there and they finish they finish the station 2 or 3 minutes earlier.
when you practice this enough, and you will practice this enough, this won't be an issue. This will not be an issue.
Yeah.
Okay, we have another comment from Mohammed.
Yes, thank you very much for this guidelines. The second one is very structured, very. I think it's better than the first one, but I have only one comment. Here in at the end of the whole answer, shall I speak about if the patient is fit for surgery or not? Because I think this patient is not fit for surgery. If I am the one who is answering, I would say I will speak with the consultant surgeon, consultant intensivist, consultant anesthetist, and I will do the NILA scoring. At the end of the day, if the patient is fit for surgery, I would take him to theater. But if he is not, I will speak to the family, start doing palliative painkillers, IV fluids, whatever. Shall I go this route or just stop for the laparotomy? This is my question.
I think it's all right. Am I muted, Yasmin?
No, you're not. We can hear you.
Okay. So I think you go for the likely course of events, really, and I think here, honestly, I think this patient will be going for surgery. He's 70, he's got just some stents, and he's usually out and about. So basically, he's an independent patient who's coming with large bowel obstruction. So I think my opinion is that he's probably going for surgery. But if you have if you're just actually discussing with you a 90-year-old corpse coming from a care home, that I agree with you, and they will make it obvious. They are not assessing you as a consultant, intensive care consultant in a very, very difficult situation. Will give you something more obvious. However, it's a fair point to mention. That's why I think you get out of the trouble by using the risk assessment tool. And you say, well, if the risk assessment tool is mentioned that the morbidity and mortality are quite high, then I will discuss it with the patient, discuss it with the family, and then get the consultant. Because essentially, you don't make a decision. The consultant does, doesn't it? So, but you give your impression that this patient, and you basically usually are talking about this patient in the ideal world who should have this. Okay, and I don't think you'll be caught out actually for that. So if you mention about a laparotomy and then they talk to you about the problems, then you say, well, quite fairly, I mean, I'll assess the patient. Just say what's happening in your practice, isn't it? You see the patient, assess the patient, get opinions, and I might have the consultant anaesthetist just come in and say, well, no, I'm not going to consider this patient for laparotomy. He'll need an ICU, and he's not for an escalation to ICU, full stop. You know what I mean? That's why you say I involve other people, and that's what they're expecting you to do. And don't worry, it won't come that tricky anyway. Okay? Why do you think this patient shouldn't be considered for surgery, just out of interest?
Sorry, what's the question again?
Why do you think this patient shouldn't be considered for surgery?
No, I'm not saying he's not, but again, we don't know what is his blood pressure now. We don't know what he's using.
Perfect. Okay.
I mean,
so act upon
yeah.
the things you know, not the things that you presume it might be. Okay. So you have enough information. This patient is dehydration. This patient is septic. You're still assessing him, and I mean, don't make it complex for yourself. Just presume that the patient will get a bit better and go for theater. Because if you go the other way around, it will be more complex. You know what I mean? And you know, this is a surgical interview. So they want to ask you about patients who are going for surgery. In my opinion, I think you just play that way.
I think it's a good point that some patients in some scenarios will not be fit for surgery, and you need to pick that up, but not necessarily this one. And I wouldn't go into all the options, because otherwise you'll never end. You can be there for 10 hours, not 10 minutes, and you're still never going to end this interview. But it's a good point to think about it. And if you read the scenario and you feel like this patient might not be fit for surgery, then go ahead and mention it, that you're going to discuss it, and go down the palliative route if that's what's needed, basically.
Yeah. And if you don't know, just mention the two options and justify it. I mean, if you really don't know, you say, well, actually, I mean, there are two options here. This option is this, justified by this, and that's what I would do to prove it. And this option is this and that. Because basically, this patient might be fit, but doesn't want to go for surgery, full stop. You know what I mean? So it's that you're actually mentioning the option if you don't have a definitive answer. But don't try to make it over complex for yourself by mentioning every single option. And as I said, I mentioned about the stent because I just presumed if it's going swimmingly like this and there's a bit more to go, probably next thing they will ask you, what are you actually going to do? Is there any other option you know about or not? And then you say, oh, I know there is an option of stenting that will probably save the patient an operation, but I don't think it's appropriate because this patient is unwell, probably having bacterial translocation and things like that. I've been asked in this particular scenario, I think I've been asked about the white cell count, why is high? This is another question I've been asked, just as an example of what people get asked about. And they wanted me to say query perforation, bacterial translocation, or aspiration pneumonia. These are the three things they asked me about. And here, obviously, you will add COVID as well. Okay.
All right.
Right. Well, thank you so much, guys.
Thank you, Romy. We're going to carry on with management scenarios. There's a chance to ask more questions at the end if someone still has questions. We're going to structure this a little bit differently from the clinical scenarios, just because we want you guys to have a little bit more practice, and we are not used to management scenarios. We're more used to clinical thinking than management thinking. So we'll try and cover it up as much as we can. So we're going to do a case and then discuss it together, basically. So if you guys, I'll give you another minute or so to read the case. Okay, so I hope everyone has had a chance to read it. So this is a scenario that I'm sure people are in every day, where you're on your own and you've got more than one thing you need to cover, basically. You've got an unwell patient and you don't have a consultant straight away. What do you do? So the mnemonic we use to answer these questions, and you can apply that to all management questions, is something called SPICE. Just seek information and identify your issues, whether they are clinical or organizational or educational, depending on the management scenario. Patient safety, and I'm going to say patient safety twice, 3 times, because it's very important and you have to mention it by name, as Romy said before. Initiative, which is basically what you can do yourself before involving other people to resolve the problem. Escalate, whether it's your senior colleagues, whether it's your supervisors, whether it's your the on-call team, whoever is around, and depending on the situation and the management scenario. And the last thing is support, which is support from colleagues, from your team, again, from your consultant, from people around you. And it's not just who can support you, but it's also how can you support people around you. So if we apply this to our case, so the issues in this scenario is you're in a clinic that's supposed to be started, so the clinic is delayed. You've got prolonging waiting times, obviously, for people, because if you're not there to do the clinic and the consultant is not there as well, no one's going to see them. You've got an unwell patient on the ward that can have multiple things, including life-threatening things like PE or bile leak or visceral injuries that need urgent intervention. So P, patient safety. Unwell patient, that's your priority, and you need to mention that yes, patients are in clinic and yes, they will be delayed, but the unwell patient on the ward is your #1 priority. Intervention, just things that you can do. So you can ask a colleague, whether it's one of your junior doctors, to go and assess the patient. You can ask nurses to start doing certain investigations for you or repeat the observations or things like that. You can ask the specialist nurses in the clinic to see whether she's happy to see a few patients while you sort out this unwell patient. You can ask other members of the team, like the on-call team, for example, or other members that are in your team as well and are doing other things, whether they can help you out, whether by seeing the unwell patient or whether by helping out in clinic. Other consultants that are around as well that might be able to help out in clinic. And when you go to see the patient, because that's the thing you need to do, again, as Romy said, you go back to the clinical scenario, but in a very short way, say, I'm going to follow the CRISP protocol. CRISP protocol, ATLS protocol, these are things that they want to hear, and these are words that you have to say. And you have to say that once everything is stable and under control, you're going to return back to clinic to finish the job that you actually started. You don't just forget about it. And then E is escalate. As you said, you can talk to alternative consultants, see who's around. You can talk to different colleagues as well. You can alert your consultant that's supposed to be covering the ward, for example, or the on-call consultant that there is an unwell patient that might need an intervention. And when you tell them early, that means that they can prepare for it. And support. So as we said, you support the team around you in clinic and you support the team around you on the ward as well. Okay, so this is how you would answer the case, basically. So now we need a volunteer to read through the case and see if they can apply the same principle or apply the same mnemonic. And I think Peter, yes, you're willing?
Yes, sorry, you said my name?
Yes, are you willing to volunteer?
Yes, let's do
Perfect.
it.
Great. So we'll give everyone 2 minutes or 2.5 minutes, which is what you have in the interview, to read through the case, and in your mind, just basically prepare the answer. Is that all right?
Yeah.
Good. So time starts now.
Okay, Peter, your time's up.
I thought I have 2 minutes. Is 2 minutes is up?
I think so. Yes.
Okay.
It's 1 minute. It's 1 minute to read the 1 minute to read.
We'll give him another minute and a half, just as if it's the interview.
Very generous. Okay.
Just to prepare everyone, there's another case after that. So if anyone is interested to volunteer, just leave a comment in the chat, please. Okay, Peter, your time is up.
Okay, this is a bit challenging scenario. So I would say that I would like to seek information and identify the issues I have now. I am in a busy shift. Apparently, I have 3 patients to see in SAU and 4 referrals in A&E. The A&E consultants are annoyed because there are patients waiting and there is no bed at the moment, which I'm not aware about them. How unwell these patients. Also, there are I have been bleeped by the matrons that the patient need to be discharged as well. These are the issues I have now: organizational issue, clinical issues. I need to be aware about all these patients, like how are unwell they, and I need to prioritize them. I have a limited team. I have an FY1, I have a CT2, and myself, and I don't have any of the consultant with me now to give some help. So how I would seek information, maybe I would answer the bleep of the ED consultant, and I would go through with him through the patient cases are weighted like to be transferred to SAU or a surgical ward, and I would prioritize them. And also I can maybe speak with like the nurse in charge in SAU and just try to seek any more information about the patient in SAU if any of them are really unwell and they need an immediate attention. I would need to organize my team. So I think ED is a safe place. I know I have I need to comply with the 4 hours waiting in ED, but ED is a safe place and they have been looked by good people. So I would send the FY1 to clear the patients in ED, and the CT2 can. Sorry, I can send the CT2 to the ED to start collecting the patient, and I can go with the FY1 to the patient in FAU or whatever. Like I can change this. My priority would be patient safety in this issue. So I would attend the most unwell patients myself with the FY1 and manage them according to CREST protocol and manage them according to the clinical management we have agreed together. Initiative, what I can do, as I said, I can seek more information. I can prioritize patients according to how they are unwell, see them, me, myself, and that's the FY1. And once I finish this, I need to review the patient in ED as well. All of them according to priority and escalate if necessary to the consultants. The problem, it's challenging here because I don't know what's the problem with the patients. So I can know which patient I need to escalate for. Finally, I would support my team. So I would like always, after I send the FY1 or sorry, the CT2 to clerical patient in A&E, I would need a closed loop contact. So I would ask them to call me back once they finish, or I would leave them and follow with them how many patients they have seen. If they ordered like the initial investigations, all the blood already, they had X-ray if needed. They started initial management, IV fluid, requested what good investigations they think they're appropriate, and I go through the patient with them again, who is more unwell and who they need me to see them first. Once I finish this, I would try to see who in the surgical department need to be discharged, to go home to empty some beds for the patient to be referred to the surgical department, and I would call my consultant to update him about all the patients I have been admitted or the most sicky ones. So this is like a general frame. I didn't like practice for a long time, so yeah.
Okay, so first off, well done. If this is your first time, you've covered, I think, almost everything. My apologies, because there's a second half of the question that is on the slides right now, is that there's also two people on the list. One's a lab chole for a biliary colic, and the other one's a 60-year-old man with diabetes for a perianal abscess. And there's a urology case, as usual, on the table. So before we dive in, how do you think you've done? What could you have done better?
I need to practice more. I need to be more structured. I won't like forth and back multiple times. Like this will be better practice.
And what did you do well?
Oh, how I did. I followed the structure. I learned today about management of management scenario. Yeah. Yeah.
Okay. And I think you kept. So I think what you did well is you kept everyone safe. You kept everyone reviewed, and you're aware of what's happening, and you're aware of your team members. I think what you can do better is never send an F1 to see patients.
Okay.
In the interview, in the context of an interview, F1s are clerking and blood taking instruments. That's it.
Okay.
Never send them to assess a sick patient, or they are assistants in theater. They are never sent to see patients alone.
My apologies. Yeah. Okay.
No, don't apologize. It's fine. So I would, if I were you answering this question, I'd say, okay, this is a difficult situation. There are numerous issues of patient safety. There are patients who have been not reviewed in SAU. There are patients who are awaiting admission under surgery in emergency department and blocking space. There are 2 patients on the emergency list who need attention, including a diabetic septic patient or potentially septic patient who needs urgent doing.
Yeah.
And a hospital in black alert, a hospital with blocked beds, and so all of these are all potential safety issues. Your priority is making sure that the SAU patients and the ED patients are not sick. So, like you said, seek information, speak to A&E, ask them what they think is going on. If anyone has a high news, if anyone has a high scoring scoring system for being unwell, tachycardic, hypoxic, etc. Anyone with an abnormally large lactate, whether they are, you're going to be a while, you'll be there on your way, but whether they are, whether they can send anyone for a CT scan if they think if it's urgent or needed, they can do these things while you're getting sorted. You can speak to SAU. Usually there's a charge nurse on SAU. They can tell you they're worried about anyone in particular that they need urgent attention. And then you can send your SHO to A&E, for example, and then you can sort out SAU because you'll be quicker sorting out SAU. While you said A&E is a place of safety, and your SHO will be confident enough to work there. You also have the issue of creating beds in the hospital. And although that's not an immediate priority, it can, although that's not an immediate priority, you can ask your consultant to do that and tell them I'll send you the F1 and you can quickly do a quick ward round, and the F1 can identify and work on the paperwork to discharge these patients. Yes?
Yes.
Also, if they're vascular patients, you can ask the vascular surgeon the same. it's not unreasonable to tell the consultant when there's a case coming onto the table, you might need to leave your ward round quickly and go do this quick case. Why? Because I'll be stuck in theatre. I'll be stuck in A&E.
Yes.
You are well within your rights as a registrar to tell them that.
Okay.
Okay, don't feel that, oh, it's an abscess, it's beneath them. No, this is a septic patient, and they need to go and cancel the lab chole as well. Tell them you'll be busy. You'll be busy in theatre, and it's unlikely that the lab chole is going to happen at 5 for a biliary colic, realistically, and the priority should be for the abscess. So either take their opinion. Do you think we can do this lab chole after hours or not? Then see what they say, but it's likely going to get cancelled. And if they can kindly go and consent the patient for that, then rebook her for tomorrow because you're busy.
Okay.
Okay. So it's a difficult scenario, and it's not just difficult because we have to say it's a difficult scenario, because it's a really difficult scenario. You have to be in 3 places at the same time. And if you've done any standard on call anywhere, this is basically the job.
This is true. Yeah, this is true.
So the way you do it is, first identify there's no one dying on SAU, there's no one dying on A&E. Second, there's no one. There's an administrative issue where they need to create beds. So the consultants can go with the F1 and identify patients who are suitable for discharge, and then they can send them home, and then we can get the paperwork done later. That's not a problem. Your SHO can start clerking patients or stabilizing sick patients in A&E or SAU accordingly, while you're sorting out doing quick admissions and triages in the other place. While the urology case is happening, the urology stent is usually about an hour from waking up to sending to whatever. So you have about an hour to sort all of this before the abscess starts. If the abscess is going to start before then the consultant can leave the ward round and go do the abscess while you're sorting out the sick patients.
There's many ways of answering the same question, but you just need to remember the structure, and you need to remember to mention clinical issues are this and this, organizational issues are this and this, educational issues. It's very repetitive, but you have to mention that, you have to say these things, because that's what they mark you on.
And believe it or not, the best way to actually do it is to practice this when you're on call or when you're on the job. And then you'll identify, all right, the sick patients are there. This is where I need to go. My team members are this, this, and this. You're going to need to do that. And then you'll find that when you face this question again, you'll be able to say it.
And it makes you efficient on the on-call as well.
And it makes it efficient on the call.
Right.
Very good idea.
Thank you very much for volunteering. We've got a second volunteer for our next case. Again, same 2.5 minutes, and then Kamel will be asking you. Hassan, you ready?
Yep.
Good. Obviously, everyone else can.
2.5 minutes starting now. Okay, time's up.
Right. Okay. So there are, in this scenario, there are a number of clinical and patient safety issues. There's quite a list that's going on, and one person who's on anticoagulants has not had INR checked, which obviously puts him in high risk for bleeding. Another patient has not been fasting for 6 hours, which obviously put him at risk of aspiration. The consultant isn't aware for the first 2 hours because he'll be in a meeting, and obviously this will affect the way I order this theatre list. I think first and foremost, to address patient safety, I would phone theatres and ask them not to send for the first patient who's on warfarin 2 days prior. I would let the patient know as well, and the theatre staff, as to why we're not sending him first on the list as was initially planned. I would ask the FY1 to do urgent clotting on him and to correct with vitamin K if required. The inguinal hernia patient would have to be delayed as well for 6 hours. I would let theatre staff know that the patient has unfortunately eaten, and I would let the nursing staff know as well, and the patient, to make them aware as to why he wouldn't be going as soon as. The other issue here is we have a patient with MRSA leg wound, and ideally we'd want him to go last on the list so that theatres can be cleaned properly afterwards. And there's a lap anterior section, which obviously will have to be done with the consultant. Because of this, the list will have to be reordered because of these issues. I think what I'll try to do first, if I can't get hold of my consultant, I will definitely try to phone him, because apart from the first 2 cases, I don't think I'll be able to do anything on my own, and I will need some senior support. If I can't get hold of my consultant, I would either speak to other consultants who are on call or are available, or even senior colorectal trainees who might be able to help me. If I'm still unable to get any advice or any support, I'd speak to the clinical lead of the surgical floor and see if they are able to provide some support in this scenario. Apart from this, I would, basically, well, I think that's it. And from a support point of view, I'd let the patients know firstly that things have changed, and the order has been changed because of these issues. I'd make sure that the theatre staff, the anaesthetists, the ward staff, and the juniors on the ward are aware of what issues have occurred and why the list has been changed, and would basically hope that when I escalate it enough, I will be able to get some support at some point, if not the clinical lead and the clinical and or medical director. And I'll keep trying my consultant. He might just answer his phone and be able to help. I think that's all
That's
I have.
it. Okay.
Hassan,
what did you do?
I think I addressed the issues that there was a patient, 2 patient safety issues, especially with someone being on anticoagulants and not having INR checked, and another patient who wasn't fasted for the appropriate amount of time. And I also noticed that, addressed the fact that there was a complicated procedure that I wouldn't be able to do without a consultant, and I needed some senior input.
And what would you do better?
I think I could be maybe a bit more structured with the approach. And I have to be honest, until the last 30 seconds, I completely forgot about the first line, that the consultant is in a meeting for 2 hours. I was more focused on the list itself rather than the first line. So I think I was going a bit back and forth and not really.
Sure. Okay. So I think what you did well is that you've identified most issues in terms of patient safety. Someone's going to bleed to death or aspirate, and identified there's a big case that's outside the realm of your competence, and another issue where there's an infected case that needs to be done appropriately. So I think you identified most things. In terms of the answer structure, you spent about a minute reiterating the question.
Yes.
Of the patient with the unchecked INR and the patient. You basically read the question back to the examiners, and what you need to do is show that you are capable of absorbing a large amount of information, breaking it down, throwing it back at them as problem and solution. So you have a patient with an unchecked INR, you can address that sometimes in people in places, on the day, the same day, the day case unit will have HemoQ or INR checks by finger prick. Maybe you can nick one of these instruments and use them to check the INR of the day, and hopefully things will be in order. Or like you say, if that failing that, the F1 can come and do the blood test, but that will take longer, obviously. And you might need to delay the patient, but you might be lucky and you find that instrument and the patient maintains their place on the list. The patient with inguinal hernia who's been fed, rather than finding someone or delaying them, you can have a chat with the anesthetist. People are already suggesting you can do, if you have an anesthetist who's competent with blocks, they can do local tissue blocks and femoral and inguinal nerve blocks for you, or under spinal. Failing that too, then you can reorder him and move him down the line. Like you said, you also need to be truthful and say, I've not done under spinal or under local or with an awake patient. Then, like you said, find someone else to supervise me and take me through, and they might be more confident to do that. With the anterior and the seeking information bit, it might be worth asking your consultant. Before he says, right, I'm off to my meeting, like, who's going to be around to supervise me? And they might nominate someone for you, and that will save you the hassle of having to contact the CD and the chief exec. But I would definitely mention that first before your consultant goes off. So say that I'll ask my consultant if he would nominate anyone to supervise. Failing that, I'll go knocking around the houses. It might be worth considering doing the infected leg in another theater first, so it doesn't infect, or in the emergency theater first, so it doesn't infect the clean theaters, and then moving on and doing the rest. So you don't lose that list order until your consultant comes out. Or that's pretty much it, really. Can anyone suggest anything else?
I think that's basically it. There is no right or wrong answer in the management scenarios. It's more how you approach it.
The more problems you identify, yeah, exactly. The more problems you identify, and that you can show that you can solve, the better. That's it. But you need, it's difficult because you can't anticipate what they're going to throw at you. So you have to try and keep it categorized as much as possible.
And if I can go back to one of the first slides, actually, Camille, that Rami talked about, which is ideas about management scenarios. And there is just like organizational issues, basically. There's a buzzword for every one of those, and it's usually audit. When you talk about that in the initiative bit, or ask my colleagues for training issues, for example, ask my colleagues to have similar experiences and things like that.
Yeah.
But we'll talk about these more later on in later sessions. But yeah, if you look at these things, these are basically ideas, and you just have to have an idea about how to answer. There's no right or wrong answer.
Where do you work, Hassan? That's a Scottish accent there. Am I right?
Yes, I work in Aberdeen, north of Scotland.
Oh, yes, okay.
ST3 Lab.
Nice.
Very well done, both volunteers. Thank you so much. It's really hard to get in front of a lot of people that you don't know and put yourself out there. Very well done. Thank you.
Well done, guys.
Thank you.
If you want to carry on.
Does anyone have any questions?
Actually, sorry, I have a question. Just regarding, in this scenario, they didn't mention what level you are. Whether you're an ST3 or an ST6 or whatever. So, your clinical or procedural competencies, would you just go with what you can actually do, and not what they assume that you can do an inguinal hernia on under spinal? So
yes. I don't think anyone's trained to do inguinal hernias under local unless you've done them quite a fair bit. So the assumption is that you're punching at an ST3 level. So as an ST3 level, you can only do a lap appendix, a simple lap appendix.
Yep.
Okay, unless you can unless it comes up somehow that you can, that you can do something else. Like if you can do a lap chole, that's fair. I think if you can do a lap appendix, that's fair. If you say that I can do a lap anterior, then that will raise a few eyebrows. So, compared to what you're doing now as an ST3, I know Aberdeen are very progressive in their training, but I don't think you can do more than a lap appendix and a lap chole. I don't think I can't do more than a lap appendix and a lap chole, and I'm a ST7.
Incision drainage of abscesses, yeah, we can do those.
yeah, fair enough. So so you're punching at an ST3 level, so keep it sensible. Like you can do if you can do a simple inguinal hernia under GA, then do a simple inguinal hernia under GA. That's not outrageous. But if it gets more fancy than that, then and also you're still a trainee and you're still an ST3. So even if you can do it and the boss is not in the room, you still need someone whose name is on the board that you can escalate to.
Yes.
And they won't say you're T7 or 8 in the scenario unless it's something like education or something like that. It's something that's not clinical skill related anyways.
They're never going to say you're an ST7 or 8. I don't think so.
Yeah, this is the day one ST3 interview.
You're interviewing as the day one ST3 registrar. If you can do a lap appendix, it's a miracle.
Right. Okay. Thank you. Thanks.
Any other questions, guys?
Okay. I'm just going to say thank you for everyone who came. Thank you for everyone who's participated. We know that they haven't shortlisted anyone yet. So that's just like an introductory session, basically saying this is how we think it's going to be, and this is how the interview is going, basically. Once they've started shortlisting people, we'll have more sessions going into more details and trying to help people to practice more and more, because from personal experience, I think Rami and Kamel will agree, this is the way you get a number. You just keep practicing and practicing until it becomes like second nature. Anyone else wants to add anything? Rami, Kamel, Amira?
It needs to be, treat this as an exam. This is not an interview, this is an exam.
Yeah, thank you so much, everyone. I do appreciate your time, and I think for those who didn't make their mind whether to go for it or not to go for it, I think it's just a free one. So probably just go for it. So at least you make your mind that way. I was just applying this to what's happened to me. I believe that's the way forward. I would think, and it's a more guaranteed pathway if you can get to it. So hopefully after the shortlisting, I think Yasmin will mention about that. We are planning on a little bit more support for you as well, guys. Getting you grouping up, and we'll try to get some mentors arranged for you to help out as well. I know some of you guys might be more experienced than some of us, but I mean that's the rules of this game anyway. So just play by the rules.
And some people are asking about slides, whether you're going to get them. We'll send you the slides as like a handout, basically. So you have it as a reference and a guide to study with. And we'll send you some feedback forms as well with the slides. So we'll be grateful if you guys can fill them out and send them back to us, please. And that's it. Any more questions before we conclude? Okay, no one's raising their hand.
Can I ask a question, please? Sorry. I want to ask something, please. If anyone is shortlisting for the interview, so it means all people, they have the same chance, and it will depend on their performance in interview, or it will depend on the portfolio and the years of graduation. I mean,
it depends.
The people who graduated like long time before, they will have like the least chance, or?
You have 3 stations, and you all score the same in management and clinical scenarios. That doesn't matter how many years you've been graduated. The only station that makes a difference is the portfolio station. You have to have more done to score higher, as in like to get the full mark. For example, if you've only graduated 4 years ago, you need 1 audit. If you graduated 7 years ago, you need 5, for example. And your final score is being multiplied by a factor, and that depends on how many years you've graduated from. So you're a bit disadvantaged if you worked more just at the portfolio station. And this is why a lot of people were disadvantaged, or it depends, because the percentage of the portfolio station is like a third now. So you're going to be a bit more disadvantaged, I guess, compared to previous years where you have 5 or 6 stations. But that's the only station where it makes a difference how many years you've been graduated.
I have a bit of a controversial opinion about the portfolio station.
Is that your personal opinion?
That's my personal opinion. It doesn't matter. Even if you have 2 PhDs and 3 papers and all the audits in the world, someone's always going to have more than you.
That's very true.
And you can't control what you can do in a portfolio station over 3 months, but you can definitely control what you can do in the other 2 stations over the next 3 months.
That is very, very true. I don't have like the greatest portfolio, and I never did really. But when you can make up for it with other stations. But this is how they score it though, so that you need to be aware of that to focus on the other stations.
Yeah, well, I agree with you guys. However, I think the way you present your portfolio is quite important. So I knew people who've done quite a lot, but actually they presume that whatever is done like in their home countries doesn't count because it's not in the UK, and this is not true. I think most of the marks that I had was from what I've done back home. Yeah, so my degrees from back home is being counted for, and yeah, and you can very easily underestimate yourself in the portfolio station. So whatever you've done since you've been to medical school or even before medical school will still count. So whatever experience you had, either clinical, non-clinical, everything really, everything. So I think you need to, when you prepare for your portfolio, you need to be very careful. And I think that for you guys, for us, it didn't matter really what you write in the application because everyone gets invited and gets reassessed again from the portfolio point of view. But in your case, we are not yet sure whether people will be reassessed for the portfolio in the portfolio station or just they're going to get their evidence verified. So I'm not sure. That's why you need to write it correctly in the application, because you won't get shortlisted if you don't write it now.
It's a very good point, Robbie. Everything counts. Everything, literally everything you can think of. If you were the leader of your scouts team back home when you were still in school, put it in as leadership. It counts.
Yeah, and you can do that. I agree with Mohammed on the whole, but I think in the very short time you can score. I remember me and Yasmin, we arranged for a training course for the F1s who were interested in surgery, and that was 3 days before the interview. And we took this to the interview and we scored maximum in training. So still things that you can do. There are still audit projects that you can do in a very short notice. So, I mean, that's...
2 days, Romy. 2 days left.
2 days, yeah, that was 2 days, yes.
No, they have now 2 days before the deadline. So I think that's that's a bit short.
Yeah, it's a bit shorter than 3 days, I think. Yeah. No, but I mean, you guys, whatever. If you pass your interview, I think you always presume that they will reassess you in the portfolio station. So if you go with like a paper that wasn't published and then published, you have a point to make that now I got the evidence, you need to score me for it, because if they have the tool to undermark you if your evidence is not enough. I think they have the tool to mark you more if you presented more evidence of more things that you have done. But I think in the 3 months you still can do things, but don't get fixed on the idea that my portfolio is weak, I'm not going to make good marks, so it's a failure. No, this is not the case.
We can always talk. I mean, once people get shortlisted, we can always talk more about how if you can push anything else more in there, project ideas and things like that. Any more questions, anyone? Okay, I'm gonna take that as a no. Thank you to everyone who came. Thank you for everyone who presented, and I hope you have a good week.
Thank you.
Thank you.